Trigeminal neuralgia is a cause of severe spasmodic facial pain affecting one or more of the branches of the trigeminal nerve. Women are more often affected than men. The pain is severe. Usually, trigeminal neuralgia affects older age groups. The trigeminal nerve is the largest cranial nerve. It arises from the anterolateral aspect of the mid-pons. It has got two parts. The sensory part is called portio major, and the motor part, which supplies the muscles of mastication, is called the portio minor. The sensory part of the trigeminal nerve divides into three. That is the reason why it's called the trigeminal nerve. You have the V1 or the ophthalmic branch, you have the V2 or the maxillary branch, and the V3 or the mandibular branch. The trigeminal nerve traverses the cerebellopontine angle before it enters the Meckel's cave. When we approach the trigeminal nerve during surgery, there are some structures that we encounter. The cerebellum, of course. Then as we retract the cerebellum, we find the petrosal veins. We see the 7th and 8th nerve complex, the superior cerebellar artery and branches can be seen, and this might be in conflict with the trigeminal nerve, resulting in trigeminal neuralgia. And you have the anterior inferior cerebellar artery, which might also be a relation of the trigeminal nerve. Classical or primary trigeminal neuralgia is the most common, constitutes about 80% of cases of trigeminal neuralgia. The pain is severe. In secondary trigeminal neuralgia, the pain is often atypical, maybe continuous, with intermittent sharp exacerbations. The etiology of secondary trigeminal neuralgia is usually a compressive lesion, either a tumor in the CP angle or a vascular malformation. Management of trigeminal neuralgia includes medical management, which basically soothes the pain. Anti-seizure medications are usually used. Carbamazepine, oxcarbazine, and gabapentin are commonly used medications which can decrease the frequency and severity of trigeminal neuralgia. Then we have ablative procedures which damage the nerve and prevent conduction of pain through the nerve. These include radiofrequency ablations and chemical injections. Ablative procedures are not ideal because it can result in hypoesthesia of the nerve, and especially corneal hypoesthesia can be hazardous because it can result in corneal opacities and blindness. Surgery offers the only way to cure trigeminal neuralgia. The steps of the surgical procedure is called a microvascular decompression. The aim is to remove the conflict or the contact between the offending artery and the trigeminal nerve. A small craniotomy is usually done. This craniotomy is done at the angle between the transverse sinus and the sigmoid sinus. The dura is opened. The trigeminal nerve is identified. It is usually at the depth. The first nerve that we normally see is the 7th-8th nerve complex. The petrosal veins can come in the way, and as much as possible the veins should be conserved. Once the trigeminal nerve is seen, it should be tracked all the way from the point, the root entry zone, in the brainstem to the Meckel scale. A vessel loop in contact with the trigeminal nerve is identified. This loop has now to be shifted away gradually from the point of contact with the nerve and the brainstem. Once the vessel loop is shifted, it is often possible to fix it away with a loop to the tentorium, but this is not always possible because branches might be at a risk of being avulsed when you transpose the vessel. What is more commonly done is an interposition. The nerve is moved away, the nerve is kept intact, the vessels are moved away, and interposition is done with Teflon felt or with fat or with fascia, so that the vessel is no longer in contact with the nerve. This procedure results in dramatic relief of trigeminal neuralgia. There are risks involved in this procedure. One, of course, is superior petrosal venous injury. Another complication of surgery for trigeminal neuralgia is hearing loss. This occurs because of stretching of the 7th-8th nerve complex. Classical trigeminal neuralgia occurs because of neurovascular conflict. That is, an artery, a pulsating artery, comes into contact with the trigeminal nerve, usually at the root entry zone, producing demyelination and ephaptic conduction. But demyelination of the nerve may also occur because of compressive lesions in the CP angle. Demyelinating diseases like multiple sclerosis may also result in atypical facial pain. Management is usually started with anti-epileptic drugs like carbamazepine, oxcarbazine, or gabapentin. There are ablative procedures which involve damaging the nerve with injections, with balloon pressure, with radio frequency ablations, or with gamma knife radiosurgery. To treat the cause, surgery is the only option. Microvascular decompression is the most effective treatment modality. The offending artery is moved away from the root entry zone of the trigeminal nerve. A cushion of Teflon, fat, or fascia is interposed between the vessel and the nerve. Relief of trigeminal neuralgia is instant and complete.